So we began last week by defining what is pharmacology, and we began by first identifying that pharmacon means drug. So pharmacon means pharmacon means drug, and ology refers to the study of or the science of the study of drugs. Well, then we realize that the study of drugs is basically we study what the drug does to the body and what does the body does to the drug. What is a more sophisticated way of saying that? Pharmacokinetics, excellent. So pharmacology, we said that in pharmacology, we study pharmacokinetics and pharmacodynamics. So pharmacokinetics and pharmacodynamics. So we need to understand what those two are. It's very important. Pharmacokinetics is what the body does to the drug. So that entails the absorption, the ingestion, the absorption of the drug, the distribution of the drug, and the metabolism of the drug, and lastly, the excretion of the drug. So that is what the body does to the drug: ingest it, absorb it, distribute it, disseminate it, and metabolize it and excrete it. And then we're gonna study the other way around. This drug that we are taking, what does the drug do to the body? And that is the mechanism of action. We're going to study the mechanism of action that enables the drug to achieve the therapeutic effects. So we're going to be studying how is the drug absorbed, and that is based on the route of entry. We're going to be looking at the factors that affect for us this drug absorption, like the route or the route of entry. Was the drug administered orally, anteriorly, in the enteric system, the digestive system, the tablet or the capsule went right through your mouth and then your esophagus, or in the nasal tube, in the feeding tube, went down to the esophagus, then into your stomach, where there is a lot of acid, and the intestine is going to absorb that drug into your circulation. So obviously a lot of the drug is going to be lost because of the acid and because of the absorption and because of the first pass effect. That's very important. We're going to be going over that today. The first pass effect. What is the first pass effect? So this is the first pass effect, is when we are ingesting and taking in the medication, and we have the esophagus, and from the esophagus you have your stomach, okay, and then from the stomach we have the duodenum, and then we have the small intestine. We have the small intestine, then we have the large intestine, and then we have the rectum. The first pause effect is when the intestinal mucosa absorbs the drug and delivers it to the excellent. It delivers it to the liver. So the first pause effect is when the intestinal mucosa absorbs the drug through arteries or veins. Veins. So that is the portal circulation. through the portal venous circulation. So now we identified the start point, the intestinal mucosa. Then we delivered the conduit who's going to deliver the drug, the conduit, and that is your portal venous circulation. Then the final destination is the liver, where the metabolism of the drug. What's another word for metabolism? Bio, bio biotransformation. We're gonna transform it to make it bioavailable and bioactive. That is the biotransformation. So this first pause effect is the effect that the drug undergoes. What kind of drug? The drug that is administered through an enteral route. This does not happen in other routes. In the enteral route with the GI, the gastrointestinal system, you have the intestinal mucosa absorbing the drug through conduits known as the portal venous. You need to know all of that. The mucosa in the intestine absorbing the drug through who? The portal venous circulation, delivering it to who? To the liver, and the liver will perform the metabolism and the biotransformation. So obviously this first pause effect is going to take a lot of my drug is lost. Just to get to the liver, a lot has interacted with the acid in the stomach, with the food that is in the stomach. It has been bombarded, and we have lost a lot of the drug. So that is through the route. So you have to understand that the route is very important. It has a lot of effects on the dosage. So obviously if I have a parent, so that's an enteral route. So your digestive system is the enteral route. The second route is the parenteral. So that is going to be the IV, is when you make an IV injection and you deliver the drug. And that is the best one because that gives 100% bioavailability of the drug. There is 100% bioavailability of the drug. 100% bioavailability of the drug because we don't lose anything. There's no first pause effect. The medication is not touching any of the acid. There is no bombardment with the food. It's immediately going to be in the blood circulation. The last route is the percutaneous route. So the percutaneous route is when we don't utilize the bloodstream immediately and we utilize the cutaneous tissues. For example, your mucosal membranes that are in the lungs. When you take the inhaler, and sometimes when we use an intradermal injection. So that is something that is not the GI, and it is not the parenteral route where you immediately dump your drug of interest into the blood. So that's a very important factor, the route of how the drug makes it to the body. That's the first important factor. The second important factor is pre-existing diseases. Pre-existing diseases. So I have a patient with liver failure. I have a patient with some chronic disease, diabetes, hypertension. So pre-existing diseases affect what the body does to the drug and what the drug does to the body. So these guys affect both. So now we are going over what are the factors that affect or influence the rate of my pharmacodynamics. Can you please just shut the door? Okay. Okay, this is not gonna bring the snowstorm. This is still gonna be hot. Okay, so it's gonna be okay. This is gonna help us. Okay, all right. Let's hope this helps us. Okay, so now we're looking at what affects our pharmacokinetics, what affects our pharmacodynamics. We said the first one is the route of entry. The second important determining factor is pre-existing diseases. So, are there chronic diseases? So now we're gonna look over. There's no eraser here. Okay. So the first thing we said that's gonna affect our pharmacokinetics, pharmacodynamics. Okay, I'm recording and I'm gonna post it for you. But if you want to take a picture anyways, go ahead. Okay. I'm gonna post this right after class, so it's really not a problem. Okay? All right. So the first factor is the drug route of entry. Then the second factor we said is the existence of diseases. This patient whom I'm administering the drug in their body, do they have any pre-existing diseases? What kind of pre-existing diseases do we have? We have we have chronic versus acute diseases. So don't forget about the acute diseases. Don't think that they are insignificant. Okay, you give a child the aspirin and they have the flu, they will develop Reye syndrome. So we care about both. Chronic diseases, these are your diabetes and your hypertension and so on. And you have your acute diseases, these are the flus and the infections. So both of them in we need to take seriously when we are considering to give the medication dosages. So the disease, we look for the disease. Is it acute versus chronic? Another thing we look for in the disease, is it liver related versus non-liver related? Why is this a very separate category? Does the patient have a liver versus a non-liver disease? Do they have alcoholic liver disease? Alcoholic liver disease. Do they have cirrhotic liver or fibrotic liver disease versus any type of non liver disease? Why are we so concerned with them having a liver disease? Yes. Excellent. So a lot of the metabolization occurs in the liver. Excellent. A lot. That means the liver is not the only site. There is the kidneys. There's metabolism that happens in the kidneys. There is metabolism that happens in the lungs and in the mucosa. But the major site is the liver. We also consider other factors when we are looking at the pharmacokinetics and the pharmacodynamics, and that is also the state of the patient. When it comes to diseases, we look for, are they malnutrition versus obese? So that is the nutritional balance. So we look for, does the patient have a lot of calorie intake? Are they suffering from obesity? Or is it the opposite? Minus, minus, minus. They suffer from malnutrition. Obesity versus malnutrition. Those two affect my pharmacokinetics and my pharmacodynamics. Also, I look for the male versus female. Okay, I don't give the same dosage to a male versus a female who are complaining of the same of the same illness. So I look for male versus female. That affects my pharmacokinetics and my pharmacodynamics. Malnutrition versus obesity. Also, the young, the young versus geriatrics, the very geriatrics, the very old versus the adult age. So that affects a lot of my pharmacokinetics and my pharmacodynamics, being pediatric, being adult, being geriatric. So these are all the factors that are going to be affecting my pharmacokinetics and my pharmacodynamics. Also, the psychological state of mind. So patients who have certain phobias of certain medications, so we have to understand that the patient has to be put in the proper state of mind. Some patients have some form of unknown idiopathic, they develop adverse effects to some medications that are generally known to not produce these adverse effects. So there's always this psychological aspect. So we will see today that there's a very important to educate the patient and make the patient, no, you don't just give them the tablet. We make them aware of what is this and why is it important. You give the right medication to the right patient and the right dose at the right time for the right disease. Okay, and you document it and the right documentation. Okay, when we examine our pharmacokinetics and pharmacodynamics, the center the center of our investigation of the pharmacokinetics and the pharmacodynamics is obviously the drug, but you can never understand the drug in isolation of the receptor ligand hypothesis. This is the most important hypothesis. All of the drugs, they operate like ligands and receptors, like a lock and a key. You see, that door, if you put the right key, that doorknob will open. If somebody else has a copy of that same key, that doorknob will not say, no, I only supposed to open to the custodial staff that have the key. No, the right key will open the right knob. But if you bring an alternative different key, it will never open that knob. So we have to study the receptor hypothesis. What is the receptor? Because the receptor is what my drug target. And we also have to understand what is the signal. We have to understand what is the stimulus, because my drug is that signal. My drug is mimicking, modulating, resembling some signal. We are trying to exogenously influence your bodily systems. You see, when we talked last week about metoprolol, we said we divide our medications, we give them different names based on the therapeutics, that they achieve. So if I have an antihypertensive medication, I call that medication an antihypertensive medication. That's a name based on the therapeutic effect that it does. How does it do that? It is a beta adrenergic blocker. That doesn't mean all the antihypertensive medications work that way, but this particular drug has that particular mechanism of action of blocking the beta adrenergic receptors. So we have to understand all of the medications work by this way. Every single medication out there, every single drug in pharmacology is always going to be some ligand that is going to target some receptor. So if we want to understand how the ligands and the receptors operate, we have to go back into the cell. What does the cell look like? We said that the cell compartment is divided into three compartments. The cell is divided into three compartments. The first one is known as the cell membrane. That's the cell plasma membrane. And you have your nucleus. Your nucleus. And what's the third department? What's the third compartment of the cell? The cytoplasm. So the cytoplasm is divided into two compartments, the swimming pool and the rubber duckies. So the swimming pool is the cytosol, That's the swimming pool. And the rubber duckies, these are your organelles. Organelles. So your receptors are going to be here. You're going to have receptors on the plasma membrane. Receptors on the plasma membrane. Receptors on the plasma membrane. You're going to have receptors in the free floating. They're floating in the swimming pool. These are called free floating cytosolic. Free floating cytosolic receptors. These are freely floating, swimming in this cytosol. The cytosol is not a solution. The cytosol is not a suspension. The cytosol is not an emulsion. The cytosol is a colloid. What is that? What's the solution? What's the suspension? What's a colloid? What's an emulsion? Well, all of them have one thing in common, and that is somebody dissolving in somebody. So a solution, you have little tiny stuff dissolving in a big solvent, like salt, little tiny glucose dissolving in water. That's the perfect example of a solution. So a solution, we're going to look at drug solutions. So a solution is known as, always there's going to be a solvent. Remember I told you, if you want to know the difference between two things, you have to look at the similarity. So all of them, emulsion, colloid, suspension, and solution, all of them, there is a solvent dissolving a solute. Little stuff dissolving in a big pool. So the solution, so now the difference between all of them is the size. The solution, you have minuscule, really tiny stuff dissolving in big fluid. So that's an example of NaCl, or a salt, calcium salt, sodium salt, dissolving, NaCl dissolving in water. That's a perfect example. Or the IV saline. That's the perfect example of a solution. Nobody's ever going to call IV saline a suspension. That's a solution, because really tiny stuff dissolving in a big pool. So that's the solution. After the solution comes the colloid. So what's a colloid? A colloid is obviously a solvent, but who's dissolving in the colloid? Protein. That's it, just proteins. Just proteins. Nothing else. No salt, no lipids. It is mainly proteins. So proteins in solution. This is tiny micro substance in solution. So here you have, and that is liquid, obviously, in liquid solution. Tiny solids. This is very tiny solids. You can't even tell it's a solution. You drink water, and you drink water dissolving. If you drink sugar dissolving in water, you drink salt dissolving in water, you can never look and just tell that they are different. That's how small they are. That's a solution. A colloid, it has protein. That's why it's a little thicker, like jelly, jello. So colloid is always gel-like. It is white because it has proteins dissolved in a liquid. And that's what the cytoplasm look like. The cytoplasm is not a solution, it is a colloid. It is solution, liquidy, watery solution. It is rich in proteins. That's why it is. How do we tell a colloid is a colloid? By looking at it. It's gel and it's white. Very good. It's white and gel. So that's two, a colloid. Three is a suspension. Suspension. Now, a suspension, obviously, you have all of them in liquid. A solution is small substance dissolving in liquid. Colloid is protein dissolving in liquid. Suspension is something in liquid. What is that? What do you think a suspension is? What is dissolving? Obviously, got to be dissolving in liquid, but what is that? Huge stuff like red blood cells. That's really thick. So it's very big. That's the exact opposite of a solution. A suspension is the exact opposite of a solution. A solution is really tiny, dissolving in liquid. A suspension is very big, dissolving in liquid, like blood. Now that's some suspension. You have big red blood cells, biconcave. You have these biconcave red blood cells dissolving in the blood, like red blood cells, very big substance dissolving in liquid. So all of these are solid, no matter how small. The very tiny, small solids in liquid. The protein is still amino acid. That's a solid in liquid. The suspension, red blood cell, is also solid in liquid. An emulsion is not a solid, is a liquid in liquid. Is when you dissolve a liquid in a liquid, like vinegar and oil, like oil vinegar dressing. So oil vinegar dressing, oil is a liquid, vinegar is a liquid, they dissolve in each other, right? So that's an example of an emulsion. Breast milk, the mommy breastfeeding the baby. So you have the milk. So when you look at a mom's, if the mom puts breast milk in the baby bottle, you look at it, it's not white like the one from the gallon milk. It's a little yellowish because it has colostrum. This colostrum is fat, lipid is fat that is mixed with milk to give the baby energy. So that's another perfect example of an emulsion. So number 4, we have emulsion, and that is liquid dissolving in a liquid, like oil vinegar dressing, like fat colostrum in breast milk, like the bile in the gallbladder. That's an emulsion. That's why they say the gallbladder makes emulsification, because it has cholesterol and it has the liquids, the cholesterol based fluids, and the enzymes that the hormones mixing up with this bile salt. So that's the oil and oil. So that's an emulsion. So now our drugs, our receptors, they're gonna be here. You have cell membrane receptor, you have free floating cytosolic receptors, and you have receptors inside the nucleus known as nuclear receptors. These are nuclear receptors. These are nuclear receptors. Receptors inside the nucleus. Nuclear receptors. Is that clear? So your understanding We're going to be looking at receptors, and you keep in mind that some medications, they're going to target receptors in the cell membrane. Other medications, they're going to target receptors in the cytoplasm, free floating. Some other medications, they're going to target receptors in the nucleus. Some drugs you're going to take, they're going straight to the cytoplasm. Other drugs you take, they go into the cell membrane. Other drugs you take, they're going to target the nucleus. The nucleus. There are some receptors on the organelles, but we don't utilize them. We're not that sophisticated yet to target an organelle. We just target, you're going to see why is it the case with cytosol and nuclear. But for now, the main key concept is you have to know if a drug is going to a target effect, it must target a receptor either on the cell membrane, cell plasma membrane, or the cytosol, or the nucleus. Very good. So we have to know very well our receptors, and we have to know really well our ligands. Okay, so when it comes to pharmacology, we're gonna focus so much on receptors, and we're gonna focus so much on ligands. They're also known as, when you see another name, don't be shocked. They're also known as stimulus. Stimulus. It is also known as signal. Tomato, tomato. It's all the same. Or a drug. So the drug is a hormone, a drug, a ligand is always going to be on this side. So this is what's going to bind. So this is the dot, and this is the receptor. So they're going to bind like a lock and a key. So the receptor is the lock, while the ligand, the stimulus, the signal, the drug, you call it what you want, that is the key. Every lock has a key, and we utilize the phenomena that we can make a copy of the key. So the drug is a copy of the key. Your body can no longer make the hormone. We make outside. So endogenously, your body endogenously make the hormone. You get older, you can't make it no more. So now we make exogenous. So we have this endogenous versus exogenous. Endogenous. So endogenously is how your body makes what it needs, the hormones it needs. Then, due to some congenital problem, due to some inflammatory problem, due to some tumor problem, you cannot make endogenous. The same way, if you cannot make something, you import it. You do a shipment, you import it. So now we're going to do exogenous, bring it from outside. Exogenous, we make exogenous supply to and still going to work, because your receptor is not just like the key. You look like endogenous, I don't care if you're exogenous, still going to work. Does that make sense? Any questions so far? Yeah, natural, produced by the body. That's the best. But exogenous, you will see now the people, sometimes there's abuse. You like the weightlifter, they can't wait for the development to take its time, and they want the muscle as quick as possible, and bench 4 plates and 5 plates as soon as possible. So they take the exogenous testosterone. So now that is now an imbalance. So they have very big muscles and really tiny testicles, because the exogenous testosterone is going to inhibit the endogenous testosterone secretion. We're going to look at that feedback. Another very important key concept. You're not going to end this course unless you master it really well. That's the feedback. We're going to see this feedback. Today we're going to see it. If you take in too much cholesterol, your cell is going to stop making cholesterol receptors because we have enough. We're full of cholesterol. The cell is going to say, the cytoplasm is so full of cholesterol, we're now going to change it. It's going to be the cytocholesterol. So it's too much cholesterol, so it's going to stop making cholesterol receptors. So when you eat the big beef burger again, the cholesterol is in the blood trying to make it to the cell. The cell will say, we already have enough. We shut down the receptor. So the cholesterol will say, okay, well, I'll hang around in the blood. I'll hang around in the blood. Is going to build up in the heart, in the blood vessels. Is going to build up in the conduits, causing atherosclerosis. So there's a feedback. Your body is monitoring the alarm. Too much cholesterol, stop making receptors. Too much sugar, we're going to stop making the channels to bring in sugar inside the cell. The cell will say, we already have enough stores and storage supply of sugar. But the person keeps on eating more and more and more sugar. So now, what are we going to do? Your tissue is going to say to the blood, I have enough sugar already. The cells stopped making the channels to bring in the glucose transport channels. So the sugar is going to start latching in the blood and sticking to the walls, and that what causes the diabetes. So that's the concept of feedback. Same thing with the testosterone. They take testosterone, so testosterone is going to feed back into the brain and say there is enough testosterone in our blood. Who's the factory to make the testosterone? It's our testicles. So the testicles, the gonads, they make this testosterone. So now they're not going to be working. So when they don't work, they're going to undergo hypertrophy. They're going to get smaller, smaller, smaller. So they have really hypogonadism. Same thing with a person who is paralyzed. A person who is paralyzed, if you look at their legs are so atrophied. Why? Because they don't have the nerve stimulation. They don't walk, if you don't use it, you lose it. If you don't walk, your muscles in the leg, your rectus femoris and your gastrocnemius muscle, they're gonna get smaller. So you see they got smaller. The same thing with the testicles. They don't make testosterone, they get smaller. Muscles, they don't get innervated, it's called denervation, atrophy. So we're gonna see this feedback. So our drugs are gonna sometimes elicit a negative feedback effect. Sometimes they elicit a positive feedback. So these are my receptors and these are my ligands. Receptors versus ligands. Receptors versus ligands. When we look at a receptor and when we look at a ligand, if we look at a receptor and we look at a ligand, we have to examine two things. If we want to analyze and we want to learn all about the receptors and we want to learn all about the ligands, we want to learn all about the receptors and we want to learn all about the ligands, we have to study two things. A student told me applied versus basic. No, that's the objective. We study pharmacology with two different objectives: to get more knowledge about pharmacology, more foundation about pharmacology, in-depth knowledge, or versus applied knowledge. We go apply the knowledge we got to make some medications to find real world solutions to COVID or cancer therapy or something like that. But if I want to understand a receptor, what do I have to master? The structure and the function of the receptor. So I have to look at the structure. I have to look at the structure of a receptor, and I have to look at the function of a receptor. I have to look at the structure of a ligand, and I also have to look at the function of the ligand. So we have to master what is a structure, what is a function of the receptor. Then I will understand how my drug works, my pharmacokinetics, my pharmacodynamics. I have to look at the structure and the function of the ligand. And that is what's going to make me understand. So if I go in my cell looks like that. So this is the plasma membrane. These are my three different components. This is my plasma membrane. This circle here, that is my plasma membrane. This plasma membrane is very interesting because it's amphipathic. Amphipathic. The plasma membrane is amphipathic. What does amphipathic mean? It's a hybrid. It's a mixture. It's two in one. It has phospholipid heads and it has hydrophobic tails. It has polar heads and it has nonpolar tails. So every plasma membrane, it has phospholipid head and nonpolar tails. Phospholipid polar head, nonpolar hydrophobic tails. Phospholipid polar head, nonpolar tails. Phospholipid polar head, nonpolar tails. And is double. So from the inside, it looks like that. Phospholipid head, nonpolar tails. These are phospholipid heads, and these are nonpolar tails. Phospholipid heads, and these are the nonpolar tails. So these nonpolar tails, they are butter. They are nonpolar. They are yellow like butter. They are nonpolar. They are oil, butter. These are non-polar. And we know like dissolves like. Birds of the same feather, they flock together. So I can never dissolve something polar in a non-polar solvent. I can never dissolve a polar in non-polar. I dissolve polar solute in a polar solvent. I dissolve a non-polar solute in a non-polar solvent. So now let's look at this problem that we have. Our plasma membrane is amphipathic. So it has a non-polar tail and it has a polar charged head. It has polar charged phosphate, polar charged heads, polar charged heads from the inside and the outside. So some students think that the inside of the cell is nonpolar. That's not true. The inside of the cell is a solution. The cytosol is a protein, is colloid. So that makes it polar or nonpolar? That makes it polar. So the inside of the cell is polar. The inside of the cell is polar. That's the inside. That's intracellular. So in the inside of the cell, that's polar. The outside of the cell, that's the extracellular. So the extracellular is polar and the intracellular is polar. It's just this yellow region that is non-polar. So if you are polar, you cannot get in because who's blocking you? Is this yellow butter, this yellow non-polar tails. And this is the basis for my receptors. I have a receptor outside here. I have a receptor outside here. This is called an extracellular receptor on the plasma membrane. I have an extracellular receptor on the plasma membrane. This is my extra, this is the extracellular receptor on the plasma membrane. Extracellular receptor on the plasma membrane. Then we said we have a nucleus. So the nucleus also has its nuclear membrane. So we have a nucleus. Inside the nucleus, you have your DNA. Inside the nucleus, you have your DNA. And I have receptors there too. I have a receptor sitting on the DNA. These are known as nuclear receptors. And here I have cell membrane receptors. These are cell membrane extracellular receptor. That's number one. So when I look at my receptors, I divide my receptors into extracellular receptors. So the receptors are extracellular receptors. And what's the opposite of extracellular receptor? So you have intracellular receptors. So the extracellular receptor, these are plasma membrane. These are plasma membrane bound receptors, like this one. These are plasma membrane receptor bound. These are receptors that are bound to the plasma membrane on the outside. And the intracellular, we said we have receptors that are on the nucleus or receptors that are on the nucleus or what? Cytoplasm, like this one. So you're either a receptor on the membrane outside, or you're a receptor in the cytoplasm, or you're a receptor inside the nucleus. This is very important that we have three compartments, and on each compartment I have my receptor. And the key thing to remember is that I have an amphipathic plasma membrane. We have an amphipathic plasma membrane. So amphipathic means what? What does amphipathic mean? Yeah, it's a hybrid. So when we say hybrid, that means it's a mixture of two different things. So what is it a hybrid of? What is the amphipathic plasma membrane a hybrid of what? Excellent. So are the polars heads or are the polars tail? Yeah, that's very important to know. The polars are the heads and the non-polar are the tails. So if I have a medication that is non-polar, it can enter. So you see, this is my plasma membrane. It has in the middle the non-polar butter. This is all non-polar. In the middle, you have a non-polar structure. This is all lipophilic. So what is philic? Philic means love, while phobic means afraid of. So lipophilic means we love the fat, we love the lipids. Lipophilic, we love the fat and we love the lipid. Hydrophilic means what? Hydrophilic. Hydrophilic means loving water, and hydrophobic means afraid of water. So now you have to make the connection, because all you need to be told is if this particular structure is hydrophilic or hydrophobic. So if you are told a particular subject is hydrophilic, so you automatically know hydrophilic means water loving, means polar, means lipophobic. You don't need to be told all of those. One is enough. So if you are told a subject is polar, so you know polar means hydrophilic, lipophobic. And if you are told non-polar, so you know non-polar, that is lipophilic and hydrophobic. And that is what makes my plasma, membrane amphipathic. That these phospholipid circles, I have two pair. I have phospholipids, I have pairs of these phospholipids in contact with the solution. And this phosphate group, this negatively charged phosphate group, is going to be dissolving with the water, the aqueous solution that is surrounding the cell from the outside. You know, the cell is surrounded by aqueous solution on the outside and aqueous solution on the inside. The cell is full of aqueous solution on the outside, polar. So aqueous is polar. We mentioned that if we say you are polar, is the same thing as saying hydrophilic. Polar is the same thing as hydrophilic, is the same thing as lipophobic, which is the same thing as, so lipophobic is the same thing as polar, the same thing as hydrophilic. While lipophilic is the same thing as non-polar, which is the same thing as hydrophobic. You got to know that. One of those will mean the other two. You don't need to be told the other two. Hydrophobic, you immediately conclude hydrophobic is non-polar, lipophilic. Polar, you already know, lipophobic, hydrophilic. So one, you can immediately know the other two. So now let's go back to our structure of the cell, this amphipathic plasma membrane that has the phospholipid heads, these phospholipid heads, and it has the yellow butter nonpolar tails. These yellow butter nonpolar tails. So if I have a medication, if I have a particular medication, and this medication wants to exert an effect, we know that it must target one of three receptors. It must target one of three receptors, either a receptor on the outside, an extracellular receptor, or a receptor on the cytoplasm, known as cytoplasmic receptor, or a receptor inside the nucleus, known as the nuclear receptor. So if you look at the receptors that are extracellular, these extracellular receptors, they are always attached either to a channel, meaning if the ligand binds them, the channel is originally shut, is closed. The channel is closed. But once the ligand binds, if the ligand binds the extracellular, if the ligand binds the extracellular receptor, so this is my ligand. Excuse me, what's happening? What's going on? What is oh my god about what? What's going on? I heard you guys say oh my god. What's going on? What's happening? Are you not interested? Okay, it's not enough to listen. You have to pay attention. You have to take notes. So this is my ligand. That is my ligand. This ligand, once it binds the extracellular receptor, let me get a better marker. Mhm. Okay, so now this receptor is bound to a channel. A channel is like a gate. This gate is usually naturally off, closed, is not allowing the passage of anything. But if a ligand binds, if a ligand binds the receptor, like for example, acetylcholine, acetylcholine. If acetylcholine binds to this ligand, to this receptor, what's gonna happen is gonna open. Because remember, we said a lock and a key. Once this acetylcholine ligand binds this receptor, is gonna open the gate. It's gonna open the channel. Once it open the channel, what's gonna happen? You're gonna have some form of influx. You're gonna have an influx, or you're gonna have some form of efflux. You're gonna have some form of efflux of some electrolyte, calcium, sodium, potassium. So you're gonna have some efflux getting out the cell. The efflux is when the electrolyte, you can have calcium getting out of the cell, potassium getting out the cell, sodium getting out of the cell. This is known as electrolyte. Electrolyte efflux, or the opposite. You can have electrolytes, calcium again, and potassium, and so on. They can either exit or enter. Exit or enter through this channel. So why is that significant? Why do I care about opening some electrolyte channel to allow some electrolyte to go out or some electrolyte to get in? Why is that? I cannot hear you. So the medication is working already because it bounded to this receptor, and that opened the channel. So you have influx or efflux depending on the medication. We're not going into detail about the medication now. But what we know is once they open, some electrolyte going in, some electrolyte getting out. So why is that significant? To help what? So if this is my medication, this triangle, it already got here. So we're not dealing with absorption or metabolism. It already made it. But once it bound, it opened. So we have an influx and an efflux. So what does that signify? Yes. So that signifies voltage change. That's electricity, voltage change. So the cell has a voltage homeostasis. So if you open a channel, allow for some electrolyte to go in and some electrolyte to go out, that is going to cause a change in the membrane voltage. That's going to cause a change in the membrane voltage. So when that change in the membrane voltage happen, that's going to facilitate an action potential, and that's how I'm going to get a target effect. So one of the ways is to open a channel. So not every extracellular, so one of the extracellular receptors is ion channels. You open them, they lead to some form of influx or efflux efflux. What's the other type of extracellular? So now there's another system of extracellular receptors. So I'm going to draw another extracellular site, and this extracellular site is going to be attached to some. Now the receptor is going to look like that. So this is my receptor. It is not a channel. If you bind, it's not going to open anything. No opening, no influx, no efflux, no influx, no efflux, no influx, no efflux. Here, you bind, you do influx or efflux. But there you bind, no opening, no influx, no efflux. So what happens then? So once we bind here, once we bind to this extracellular, once we bind to this extracellular receptor, once we bind to this extracellular receptor, just like here, we bound to the extracellular receptor, the ion channel opened. The ion channel opened. But here, when we bind the extracellular receptor, the ion channel is not going to open. What's going to happen? So what's going to happen now if the channel, so this is the channel, once it binds, it open. This one is not a channel. Once it binds, it causes, the domino effect. You tip this one, the other one will tip over. Then the other one will tip over. So you have a cascade known as intracellular signal transduction cascade. So you have, this is your number one. Then you have number 2 protein here. This number 2 protein was off. It was off. But once you bind, once the ligand binds the receptor is going to undergo some mechanical, conformational change. So it's gonna start spinning. This receptor here is gonna start spinning, or it's gonna start dimerizing, and it's gonna start shaking. Once it starts shaking, the protein that is right next to, remember they are domino, they are all next to one another. They're all next to one another. You tip one over, the other one will tip on the others. So here you initiated the first receptor. You initiated the first receptor, the protein who was right next to it, known as the G protein. That's why they call this receptor G coupled protein, because it has a G protein coupled to it. It's like a domino. If you tip the receptor, the G protein is going to start getting activated. So usually here, the G protein is off. In the beginning, the receptor was off, but when the ligand bind, it turned on. When the receptor was on, the G protein was off, but when the receptor was on, it was off, it turned into on. Then the G protein is gonna activate another in the remember the domino effect is gonna activate another protein known as, for example, adenylyl cyclase. So that's the adenylyl cyclase. That's protein number 3. It was off, but when G was on, it turned it from off into on. Then we're going to continue. Adenyl cyclase is going to turn on another protein known as cyclic AMP, CAMP, and CAMP was off, but who turned it on? The one that's right before it. So now it became on, and then cyclic AMP is going to activate my target enzyme, and my target enzyme is going to give me my target effect, what I need, my target effect. So here you see like a chain reaction. Here you see like a domino effect. It began with the ligand. So the ligand bound to the receptor, it was on. When the receptor was on, the G protein was turned on. When the G protein was turned on, adenyl cyclase was turned on. When adenyl cyclase was turned on, cyclic AMP was turned on. When cyclic AMP was turned on, the target enzyme was turned on. It was off, but now it's going to be on. And then the target enzyme, it gave me the target effect. So here we had no channel, no electrolyte enter, no electrolyte exit, no influx, no efflux. Here we have what is known as signal transduction cascade. Cascade is like a domino effect. So you turn one, the other one right after it. Turn one, the other one right after it. You turn the one, then until you get your target effect. So in both cases, in the first case, my ligand acetylcholine opened the channel. Then I had a membrane voltage change. That was my target effect. I'm done. Just opening the channel, electrolyte and influx, electrolyte efflux. That is known as the target effect. I'm done. But with the other type of a receptor that is not ion channel, that is the signal transduction cascade.
Is it the signal transduction cascade that leads to the target effect? So is it because of the first one that we have opening?
So they are not connected. They are two separate systems. They are not connected. These share one thing. Both of them receive ligands on the outside. They are extracellular. Hold on. Let me answer the question. So both of them are extracellular. But one extracellular would open and allow influx or efflux. That's done. That's it. That's the target effect. That one is a separate one. So this one is acetylcholine. That one is known as epinephrine. You know the fight or flight? Epinephrine. So that's how epinephrine works. Epinephrine works not by it opening a channel, by a signal transduction cascade. Acetylcholine open a channel. So you see there are two different ligands working with two different extracellular receptors. So in the end, they are both what? They are both extracellular receptors. But one is ion channel related, lead to influx and efflux. That is known as the acetylcholine. Acetylcholine receptors. While the other system is the signal transduction. Signal transduction cascade, or the G protein coupled G, because it's coupled to a G protein. So that's known as G protein coupled receptor. So you see, that's a G protein coupled receptor. Both of them are extracellular. But one, once it opens, it allows the entry or the influx or the efflux. While the other one, once activated, will give me a stepwise. That's step number one, binding of the ligand to the receptor. Step number two, activating a G protein. Step number three, activating adenyl cyclase. Step number 4, activating cyclic AMP. Step number 5, activating my target enzyme to give me my target effect. All of that is happening in the cell based on extra. So both of them, whether acetylcholine or epinephrine, both of them are dealing with what kind of receptor? Extracellular. This is not happening inside. It has effects on the inside, but we did not bind on the inside. Yes, your question is. So don't say the first one. I have a lot of names here. I have extracellular receptor, ion channel, signal transduction, acetylcholine, epinephrine. So mhm. Yes. Very good question. So there is an enzyme inside the cell. So enzymes are responsible for certain functions. Some enzymes are responsible for speeding up the metabolism. Others are important for breakdown of sugars. Others are responsible for stopping the cell cycle from dividing. So we have different target effects: stopping the cell cycle from dividing, tumor suppressors. We have glycolysis, breaking down of sugars. We have beta oxidation, breakdown of lipids. So we have different metabolic effects. But the enzyme is off. If you turn it on, it will do its target effect. But the thing is, it cannot be turned on unless you have that particular epinephrine ligand. So the receptor is also named after the ligand. So that's an epinephrine receptor. That's a acetylcholine receptor. So the target effect is, so for epinephrine, I'm so stressed, like, fight or flight. I'm chased by a lion. A lion is chasing me. So I need to break down glucose so I can get energy, ATP. I need to break down the proteins to get ATP. I need to break down lipids to get ATP. So once I do all of that, I need my target enzyme to do that metabolism for me. But the enzyme is off. So I'm waiting for it. That's why epinephrine runs through your body to do that. Because if there's no epinephrine, you're not going to break down the sugars. You're not going to be able to run. Your skeletal muscles need ATP to help you run from the lion or whatever that you're afraid of. So that is your extracellular division. So your drugs are going to do that. Your body makes acetylcholine, but Johnson and Johnson are going to make somebody that look like acetylcholine who will bind the acetylcholine receptor and do the same effect, open the channels. Another company making Advil, they're not going to make epinephrine. They're going to make somebody that look like a copy of epinephrine. Once you take it, it's going to do exactly the effects of epinephrine. And that is just extracellular. You now have, but remember, this ligand here, we said it's called a stimulus, it is called a signal, it is called a drug, it is called a ligand, it is also called the first messenger, a first messenger. So this is the first messenger. So this first messenger, it binds on the outside. It cannot get in. The first messenger bound on the outside. Why did it not go in? Why did this epinephrine go zoom right inside and turn on my target effect? Why did it need this domino effect? This guy tell this guy, this guy tell that guy, this guy tell that guy. Why can't it just go by itself, do that by itself? Why did it need a second messenger? These guys are second messengers. This cyclic AMP is the second messenger. Why did the first messenger in the extracellular need a second messenger? Because it has what? Yeah, because it is non-polar. This is a non-polar yellow fence. It will block it. It will prevent it from going in. So now I don't need to tell you, is epinephrine and acetylcholine polar or non-polar? Raise your hand if you think epinephrine and acetylcholine, who bind on the outside, they cannot get inside. Raise your hand if you think that they are polar. Raise your hand if you think that they are non-polar. If they are non-polar, they would have went in. Because remember, yellow dissolves yellow. Non-polar dissolve non-polar. If they, you see now, if somebody want to pick you up, Uber, can they get inside here, pick you up, take you out? They cannot. They need a second messenger. So they tell the security, tell somebody, somebody's gonna walk up the stairs, the second floor, then somebody go to the third floor, then somebody's gonna come here to tell you. But if the Uber driver was already one of the students here, they can just themselves go in, as we will see with the intracellular receptors. Intracellular signals, they go right through. You see, they bind to two and they bind to the nucleus. They don't need a second messenger. But these guys, because they are polar, epinephrine is polar, acetylcholine is polar. That's why it cannot dissolve in the yellow, the non-polar. If epinephrine and acetylcholine were non-polar, why they need an extracellular receptor? They can just go in. They are the same. They are part of the school. They are part of the school. They have the ID. They can get in and take you out and take you, let's go to the Uber. So same thing with this. Acetylcholine cannot get in because it is not yellow, because it is not polar, because it is polar. It is not polar. It is polar. But the other guys, this one, number 2 and number 3, binding into the cytosol, binding into the nucleus. These guys are yellow. These guys are definitely non-polar. These guys are these are cholesterol based. These guys are non-polar. These guys are non-polar. These guys are non-polar. You see, they are yellow, just like the plasma membrane. I put them in yellow because they can enter the cell. They don't need a second messenger. They are a first messenger. They do everything on their own. They bind to the cytosol, free-floating receptors, and they bind to the nucleus receptors. So intracellular receptors are non-polar. Intracellular receptors are non-polar, and intracellular receptors, they are, I said, one is enough. Non-polar means hydrophobic and lipophilic. So intracellular receptors have non-polar ligands, and once you bind them, so now we said if you bind the extracellular, you can have a channel open, like here. You can have a channel open, or you can have a signal transduction cascade. And these guys are polar. Extracellular receptors deal with polar ligands. While intracellular receptors, they deal with non-polar ligands. This is very important. Extracellular receptors deal with polar, while intracellular deal with non-polar. Okay, so now we know that extracellular receptor, you bind them, channel open or close. influx or efflux. You bind another type, signal transduction cascade. Now, this inside receptors in the cytosol, we said there's two kinds. We said that the intracellular receptors, they're either cytosol, free floating in the colloid, free floating receptors, like this one is free floating, is chilling here in the cytoplasm. Or it could be elsewhere. Where else it can be? Free floating in the cytosol or the nucleus. So in the cytosol or the nucleus. So there are cytosol free floating receptors or nuclear receptors. Either way, cytosol or nucleus, you're in, you're yellow, you're not outside. You don't need somebody else. So what do they do once they are inside? They open a channel. Do they make a? So what do they do then? Yeah, so they go right through. Once they went right through, they bound here or they bound here. What are they gonna do next? They're gonna do the same thing. They're gonna do the same thing. So once this free floating receptor binds its yellow ligand, is gonna mobilize. It's called the mobile receptor. So the free floating receptor is gonna mobilize, known as the mobile receptor. The mobile receptor, known as the mobile receptor theory or the mobile receptor hypothesis. You bind the yellow and the receptor is going to start moving and is going to migrate to enter into the nucleus. Even though it's free floating, once it binds the receptor, it's like a submarine. It's going to take that first messenger to the inside of the nucleus. Or the ligand is going to go all the way to the inside, is not going to mobilize. But in the end, both of them are going to go inside the nucleus. And once they are inside the nucleus, what's going to happen? They're going to transcribe the DNA. They're going to transcribe the DNA. So once this free floating intercellular receptor binds the ligand, or once the nuclear receptor binds the ligand, both of them, they're going to transcribe the DNA. So they're going to transcribe. It's like the pharmacy. You take a prescription, they're going to read it, they know exactly what to give you. So these are on demand. So it's like when you call Tesla, you say, make a car for me. So then they make it on demand for you. So these intercellular receptors, they're all about in-demand supplies. The cell right now need a cholesterol receptor. They will make an on-demand transcription of a cholesterol receptor. The cell right now, you had very sugary soda drink and there's a lot of sugar in your blood. The cell need to take it. The cell will make transcription of a glucose channel to allow for, not electrolyte channel, glucose channel to bring in glucose. So that we make on-demand supply for the cell by DNA transcription. Extracellular has nothing to do with DNA. Extracellular systems do not have anything to do with on-demand. There is already ready-made enzymes that are off. They just need to turn them on. So extracellular receptor, you're in a dealership. The car is there. You go, you buy the car. But the intercellular, they make it for you on demand depending on how you're feeling. So this cell right now, you take a photo of it before you have a meal. Then you have a meal. You take a photo afterward. You think the cell membrane gonna look the same? It's not. Why? Because on demand, before you had no sugar in your blood. Now you do, so your DNA is going to be transcribed to make sugar channels. So now you're going to notice after the meal, your plasma membrane has more sugar channels than before. After the meal is done and you burn the sugar, you take another photo, the sugar channels are gone because they did their job. So that's why we said this plasma membrane is like the universe, is changing. You get a telescope, take a photo, this Hubble telescope, you take a photo of space, you see that planet over here, that star over here. An hour later, you take a photo, both are gone. Something else is there. Same thing with your plasma membrane. So your plasma membrane is changing like the galaxy based on what's happening. Are you starving? Did you eat? You eat what? Lipid or sugar or protein or veggies. So it's changing based on the DNA. So you have to understand the significance of the DNA. So we looked at, remember when we began, we said we're going to look at receptors structurally and functionally. We did, right? We looked at the receptors. We saw that some receptors are outside, others are inside. Then we looked at some receptors bind polar, like acetylcholine and epinephrine, while other receptors bind non-polar, yellow, like the free-floating receptors and the intercellular receptors, intranuclear, inside the nuclear receptor. Then we looked at the function. Remember, we said we look structurally and functionally. So we know now, functionally, some receptors open a channel, some receptors do a signal transduction, and other receptors make a DNA transcription. So now we are done with receptors. Structurally and functionally. You're going to go home. I'm going to post this video. You're going to watch it home. If you think you're going to come in this course and you just sit and I lecture for 3 hours and you come deal with me again the next week for another 3 hours, I promise you, you will not pass this course. You have to go home and watch. It's expected. At first, nothing is gonna make a lot of sense. But when you go home, you give yourself a round two. You look at the study guide I'm gonna post for you. You look at the multiple choice questions, and you watch this video that I'm gonna post. Then things slowly, or with repetition. All of this, I was a student one day, but because I read, now it becomes like a story. For me, it's like I'm telling a story. I already know it. But I didn't know it. I had to learn it. So now you too. You have to go, you have to sit down. I know it's 7 p.m., the brain is off. So we are fighting it, we are pushing it. But that's how we're going to train it. So then in the weekend, so now that's a round one. So you go in the weekend, you give it a round two. Then next day, round three. Then round four. This is not a course where you fall behind. So our first exam is going to be in 2 weeks. So next week, we're not going to have an exam. We're going to finish up. We're going to be up to date with the syllabus. And the next week, then I'm going to give you your study guide and your homework questions. Study these homework questions really well. The exam is going to be replica, very similar to these homework questions and the study guide. And these videos you're watching and you're paying attention to, that's going to help you a lot. I'm not going to ask you about something else. I'm teaching this. I'm going to ask about something else. I'm going to ask about this. Does it make sense? I'm going to ask you about that. So you come here, you pay attention, you do the video summary that I'm going to give you, and the homework questions, and the study guide, and you will see that you're going to come on the exam. I'm not tricks, no critical thinking. This is not the IP, this is not the PI or the IP or the intelligence quotient test or IQ. It's not about that. You learn, you move on. Yes, I'm going to let you know about that. Now learn, and then where is going to be on the ATI? Is it going to be on a Scantron? Is it going to be in the Yankee Stadium? We deal with that later. For now, we are concerned and worried about learning the content and not falling behind. Okay? Of course there's going to be. And this, so this is the book that is assigned by the syllabus. This is the book that is assigned by the syllabus. This is the OpenStax book. Never in mankind was one book enough to study a particular subject. There's always a supplementary book that goes with it so things now can make sense. You don't just rely on one and go home and you got it. No, there's always a supplementary means is useless, is not important. No, it's very important. So when you read them, then they're gonna go in hand in hand. But obviously, you're not gonna like drown in the words. You're not gonna like absorb all the information. I'm gonna focus you. I'm gonna give you a study guide and homework questions. And do you think I talked about every single thing in these books? Obviously not. But I'm gonna talk about the major concepts. And with my study guide, I'm gonna focus you and guide you on what to focus on and what to be responsible for. Okay? Yes. They give you this book. That is online, free. I said that last week. OpenStax is free. They have the PDF. So do what I do. I staple it. You see the staple? I print it. I printed the chapter. I read it. I stapled it. It made perfect sense with this. So they go together. Relying on this only is not going to do the job. You need both. Okay? The nursing pharmacology for LPN, this one, and on the OpenStax. Yes. Okay. No, this is not true. Anything on Brightspace, forget about it. They have an F there. Forget about that. I'm going to post for you. Worry about what I post. So I'm going to be making an announcement. All of that was the previous. They imported the course content. So I'm going to post for you the lecture slides. I'm going to make an announcement. This is homework due on this date. This is the study guide. Solve it. Post it here. This is the video you need to watch and summarize. And the exam is going to be, I'm going to be doing that. So worry about what I tell you. As we're going on, I'm going to be deleting and canceling maybe all of the stuff that's there. So don't worry about what's on Brightspace. I got my access to it yesterday. Just now, I'm going to be making an announcement and assigning everything. Yes. I think the syllabus is already there. Yeah, I'm following that one already. So now we're going to go over the slides and I'm going to be giving you the study guide and the homework. Yes. No. No. The book, you see that book? That is what the syllabus is. That is the primary. The red one that I held, that is the primary ATI book. The OpenStax is the supplementary that's going to explain it. Yeah, it's there. It's on the syllabus. Yeah. Okay. Yes. Of course, graded. No work is done. You show up, that's a grade. You do the homework, grade. The summary for the video, grades. The study guide, you answer that, post it, grade. Everything is graded. Nothing is just out there. Credit for everything. Okay, I need to continue. If you have a question about anything, please send me an email because we don't have a lot of time. Okay, so remember we agreed that we need to study receptors, structure, and function. So we're done with receptors now. We're done with receptors. We're done with receptors. We're done with their structure. We're done with their function. Now what's left is the ligands. What is now left is the ligands. So we look at ligands, structure. We look at the structure and function of the ligand, structure and function of the ligand. Obviously, the structure of my ligand is going to be what? Polar versus non-polar. And polar, an example of that, we said we have epinephrine and acetylcholine. Excellent. Acetyl, excellent. You guys got that. After 7 p.m., you got it. I'm proud of you. Very good. Excellent. I'm very proud of you. Now, non-polar is all gonna be what? Based off what? You know, the pancake, the cookies, all of it based on flour from dough, flour, butter, and milk. So all of the non-polar enzymes are based on what? All of them, not some, not most. All of them are based on what? Cholesterol. These are cholesterol based in their structure. So these are polar, non-polar. What is the function of the polar? The function of the polar is to open some channel like like acetylcholine, or what else do the polars do? Signal transduction cascade, like epinephrine, with the G protein coupled to it. G protein coupled receptor. Excellent. Then you have a non-polar. You have non-polar. These guys, they are always there for transcription. So the non-polar, they are there for transcription. So now let's deal with this transcription. What is transcription? Yeah. Yeah. So there is no other transcription. There's only one kind of transcription. Okay? All right. So we have what is known as the erase what? Okay, it's on the video. You can see it there. Because we need to move. It's a lot. The central dogma of biology. What does the central dogma of biology say? The central dogma of biology says that we have DNA inside the nucleus, then we transcribe the DNA. We have transcription, we have transcription of the DNA, and that will give us RNA, and the transcription of the RNA is going to be, the transcribed RNA is going to be translated. So I have translation. So this translation is going to give me my protein. The translation is going to be my protein. Is going to give me my target protein. This target protein is going to give me my target effect. So I have my target protein is going to give me my target effect. The target protein is going to give me my target effect. So that's the central dogma of biology. I go from one through transcription, and that is inside the nucleus. Obviously, inside the nucleus there, I have my transcription of the DNA to the RNA. And then from the RNA, I translate the RNA into my target protein. That is known as translation. And then after I translate to the target protein, I get my target. After I get my target protein is going to give me my target effect. My target protein can be an enzyme, can be a transporter, the glucose transporter. It can be a receptor for cholesterol or lipid, but that's how I'm going to get my target effect. So if these guys get activated here, this free-floating cytosol receptor or the nuclear receptor get activated, they're going to do this. They're going to go in the DNA, they're going to transcribe the DNA into RNA, then the RNA is going to go in the ribosome. Translation is in the ribosome, in the cytosol, while this transcription was in the nucleus. The translation is in the ribosome, in the cytosol, to give me my target protein. My target protein is going to give me my target effect. That's what's going to happen when I have a nonpolar yellow intracellular ligand that's gonna cholesterol based. These are all based on cholesterol. All of the hormones, all of the drugs that are gonna go inside, they're gonna go inside the cytosol or inside the nucleus. They are going to make for me transcription. When we do the retroviral medications for like HIV, they learn that HIV violates this pattern. So you're supposed to have one DNA, you transcribe to RNA, that's two. Then you get your protein, target protein, that is three. Then the target effect, that is four. They realized the virus has a very sneaky way of operating. So, what does the virus do that is very dangerous and very sneaky? The virus, the virus does not have a DNA, obviously. The virus has this helmet here, this structure, and it has RNA, only RNA. Once it attacks you, it's going to make all of the RNA enter into the cell. Once the RNA enters into the cell, there is a dangerous enzyme known as reverse transcriptase. Reverse transcriptase. What does reverse transcriptase do? What does reverse transcriptase do? From the name, reverse transcriptase. Don't invent or discover something. It's already known. So reverse, it will go from 2 to 1. It will go from 2 to 1. Instead of going from 1 to 2 normally, it will go in the opposite direction because it only has RNA. So it has viral vRNA. It has viral RNA. So when the HIV virus attack you, it will put inside your cell vRNA, viral RNA, along with who? Reverse transcriptase. So this now reverse transcriptase is gonna take the vRNA, the viral RNA, the vRNA, and it's gonna reverse transcribe it. So let's say the RNA was uracil, guanine, cytosine, uracil, adenine, cytosine. It's gonna reverse. You're gonna get an A. G, you're gonna get a C. C, you're gonna get a G. You're gonna get an A. A, you gonna get DNA doesn't have uracil, it's gonna have thymine, and G. So it reversed the complementarity. And what did it give you? It gave you viral DNA. It gave you viral DNA. So reverse transcriptase was able to take the vRNA, the viral HIV RNA, convert it to viral DNA, even though it has no DNA. It just has RNA. It was able to reverse the RNA into DNA. Once it reversed the RNA into DNA, your human cells, they don't know any better. They don't know that as polymerase, who does the transcription? These are polymerase enzymes. Polymerase. These are known as RNA polymerase because they make polymers of RNA. They call them polymerase, RNA polymerase. They polymerize RNA. But their problem is they don't know. These are human RNA polymerase. These are hRNA human. These are human RNA polymerase. So the human RNA polymerase will see the viral DNA. They don't know this is viral DNA. They think it is human DNA. So you will have your human RNA polymerase transcribing viral DNA because the viral destroyed all the human DNA. So the polymerase, they don't know. If you go in a store and you give the grocery store guy $10, does he care you got it from nurse paycheck or from selling drugs? He don't care. It's $10. Same thing, the polymerase doesn't know. DNA is DNA. It doesn't know if it's human DNA or viral DNA. So the virus destroyed all the human DNA and reverse transcribed viral RNA into viral DNA. So the human polymerase, RNA polymerase, is going to start transcribing viral DNA into viral RNA. And the human ribosome, they don't know any better either. They're going to take the viral RNA and translate it into viral proteins. And the viral protein is going to give you viral target effect and kill you. So the virus hijacked your own human machinery to destroy your own cells using the reverse transcriptase of the central dogma of biology. But for these guys, the yellow, the nonpolar, what do we need? We need, remember, testosterone. That's an example of a cholesterol-based hormone. That the one that the effects of testosterone is the musculature. So when they take the exogenous testosterone, is it gonna bind outside or inside? Testosterone, is it gonna bind outside or inside? It's gonna go inside. It's gonna transcribe DNA to RNA. RNA is gonna give you testosterone proteins. These are the proteins that will exert the target effect of testosterone, musculature, and the essential. That's why they call it essential hormone for the man. The man lose essence if he doesn't have the testosterone. Women, the essential hormone for women is estrogen. That's the essential hormone for the woman. That's the essence of the woman, is the estrogen. It's also cholesterol based. It also goes inside the cell. And the last thing, whether you are, let's say you don't bind to the inside receptor, you bind to the outside, what's going to happen here? It's called the mobile receptor. Is going to start mobilizing like a submarine and go inside the cell and transcribe. These are transcription factors. Intracellular and intranuclear cytosolic receptors, they are transcription factors. They are transcription factors. They transcribe the DNA to RNA, then get the proteins that do the target effect. So we're going to see that our drugs are like that. They are always trying to be like testosterone, like somebody, trying to be like some antibiotic, trying to be like some antiretroviral, like try to be some type of, as like acetylcholine, open some channel that is blocked, not open, or close some channel, or make some receptor dimerize, conformational change, make a cascade. So these are, now we did it. We did the receptor structure and function, and we did the ligand structure and function. Any questions about structure and function of ligand? Any questions about structure and function of receptor? We did the first pass. We did the liver, and we said that the liver has the enzymes, that the cytochrome P450, the CYP, the CYP cytochrome P450 enzymes, the cytochrome P450 enzymes, these metabolize or they metabolize our medications. We talked about the different routes. And when we take the medication, what is the, if you take a particular medication, what is the MEC? Minimal effective concentration. The minimal effective concentration of a drug, let's say you took 5 milligrams, and the 5 milligrams, this is an antihypertensive. Are you guys following me? Shh, in the back. So if you have hypertension, you take 5 milligrams, your blood pressure does not change. You take 6 milligrams, your pressure does not change. You take 7 milligrams, your blood pressure starts dropping. You take 8, start dropping even more. So the minimal effective concentration was the 7, because that's the minimal, the least amount that showed the therapeutic effect of your blood pressure going down. So the minimal effective concentration, the MEC, the minimal effective concentration so the minimal MEC, the minimal effective concentration of a drug is the minimal amount, that you can take that will enable you to observe the target therapeutic effect, the minimal amount that produces effective therapeutic response. So you have to take at least this amount in order for you to be able to see an effect. So 5 milligrams may work for me, but they may not work for somebody with liver disease. They may not work for a female. They may not work for the obesity. So our MEC is different depending on the pharmacodynamics and the pharmacokinetics. Yes, you had a hand up. Okay. So our MEC is not a one size fits all. It depends on child versus pediatric versus geriatric. So all of that is affected. Your MEC is affected by that. And what is the onset of the drug? Drug onset. When you take a drug, exactly. When onset is the time. So now you give your medication, antihypertensive medication, to a patient, and you're looking in the clock. The blood pressure is still 160. Then 160 over 120. So you give them the medication, and 5 seconds pass, nothing. 10 seconds, 30 seconds, 45 seconds, start dropping. That's the onset. When it first, the time, onset is a measure of the time. Minimal effective concentration is an amount of the drug, but onset is a time factor. It took me 5 minutes to administer that dose so that I can see an effect. So that's the onset. What's the peak? The peak of the drug effect. The peak is also a time, and how long did it take for me to see the maximal effect? So if it's antihypertensive, how long did it take for my blood pressure to go from 160 to 120? If it took 45 minutes, then the peak was in 45 minutes. And the concentration of the medication led to a peak therapeutic effect at 45 minutes, where the drug now finally arrived to 120. It didn't go even lower. If it does not go to 119, it stays. The peak is 120 at that time. If it went down to 119, then you got to count some more. So you see the maximal therapeutic effect. Then it's got to start going down. So that is the the peak. And then there's the therapeutic window. What is the therapeutic window? The therapeutic window is this dose. The therapeutic window is the dose. If you add too much of the drug, if the dose is too much, the maximum limit, that's going to lead to toxicity. So the therapeutic window, if you add too much of the drug, you're going to have toxicity. If you add too little, minus, low, 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 low. If you drop, minus, that is going to be known as subtherapeutic effects. So you're not going to have any therapy. So the therapeutic window is a concentration. It has to be between this milligrams and this milligrams. If you give below this amount of milligrams, you're going to have subtherapeutic. If you give more than this milligram, you're going to have toxicity. Whatever in between, that is your therapeutic window. Yes. No, it's not the same as the therapeutic index. The therapeutic index, we're going to look at a value. So we're going to assign a value on how effective the drug is. We're going to talk about that. But the window is a range, This ranges from one to two things, either from being subtherapeutic, useless. If you give below this milligram, let's say the therapeutic window is from 100 to 200. If you give below 100, it's useless. Sub therapeutic. It's not going to do any therapy. If you do more than 200, that's toxicity. So obviously, the longer the range from 100 to 500, the better. So the longer the therapeutic window, the bigger the therapeutic window, the better the drug. That's very important. And the half-life. What's the half-life of a drug? A half-life is a time will pass by and and whatever that was in the blood will become half. So for example, I take 100 milligrams of a particular medication that has a half-life of an hour. That means after 1 hour, so let's say it is 100 milligrams. I have 100 milligrams of a drug that happens to have a 1 hour half life. It has a half life of 1 hour and 100 milligram drug. That means if I ingest it 1 hour later, how much of this 100 milligram drug is in my body? 50. Excellent. So now I have 50 milligrams. An hour after that, how much milligram is left in my body? I'm sorry? 0. No. Half of whatever that was there. So 25. Excellent. And another hour. Remember that the half life is an hour. So another 1 hour after that, the 25 is going to be 12.5. Another hour after that is going to be 6.25. Another hour after that is going to be 3.12, and so on. So a half-life means when an hour passes, whatever that's in my blood is going to be half. Yes. Even when what? Yeah. Immediately. No, the moment you administer it, because we don't just, we're looking at its bioavailability. Once it's in my system, they immediately count it as, once it reaches the circulation. We're not going to wait for all the drug, and we cannot actually assess for it till it reaches the receptor. So once it's in my body, an hour later, depending on, maybe some of them have half an hour, then that means it's going to get half. Not when I see the effect happen. And also, that's a very good question, actually. Another thing is it better to have a long half-life or a short half-life? Raise your hand if you think it is better to have a drug with a long half-life. Raise your hand if you think it is better to have a drug with a short half-life. So if you think it is better to have a drug with a long half-life, why do you think so? Why? Yes. If it's a long time, it's gonna cause toxicity when you get it out. So the one with a short half-life, get out, get in, get out. It's gonna build up on the bone, it's gonna build up on the liver, it's gonna build up on the lipids, so that's dangerous. Okay, alrighty, so now we're gonna do the slides. Alright, so take a 15-minute break. So yes. Mhm. Drugs that are what? Long-term treatment. Yeah, what about them? So what does a long time, a chronic, you mean like a chronic disease, a medication for a chronic disease? Yeah. Guys, please, let's pay attention. Your classmate has a question. So long-term treatment meaning you take that drug with that particular half-life for a long time. But it doesn't mean the drug has to be in the body for a long time. I take it every 3 days for a year, or maybe like a HIV treatment for a lifetime. But it doesn't mean that it has to be in my body for a long time. Okay? All right, guys. So let's take a 15-minute break, come do the slides, and then you go home.